All right. Well, we will get started just momentarily. All right. Well, we'll go ahead and get started. So those of us who are on time, we can get going, and then we'll have some join. But this is our next installment of our Vet Chat series here at the Grayson Jockey Club Research Foundation. I'm Jamie Hayden, the president of the foundation. And joining me this week, or this time on our series, we are so proud to have Dr. Aileen Rowland from the University of Texas, or Texas A&M University, excuse me. And she is the winner of the Elaine and Bertram Klein Development Award. And this is a competitive grant program that we give out here and have at Grayson to promote the promising investigators, providing a one-year stipend salary. So we get grants or submissions from postdoc recipients and award winners all over the country that want to further their career. And then we select those winners out of that pile of individuals. Now, Dr. Rowland is going to be telling us about something today that is plagues a lot of our horses, which is the osteoarthritis malady. Happens at age groups all over, different ages of horses, depending on what breed, discipline, exercise load, and I'm sure we'll hear more about that. But I just want to say again, congratulations to Dr. Rowland. Thank you for joining us today. We really are appreciative of your work that you're doing down at Texas A&M and for submitting your work to Grayson and allowing us to fund it. So thanks again, and I'll turn my camera and turn it over to Dr. Rowland now.
Perfect. Thank you so much for that introduction, and thank you again for the support. I do really appreciate it. It's really helpful in my training and progression through my career. So like I said, I'm going to be talking today about the use of mesenchymal stem cells for osteoarthritis. The crux of my work has been on developing an alternative method to culturing MSCs that eliminate Xenogen proteins. And so today I'm going to be going through the work that I started in the lab all the way up to some clinical work that we've done so far. So first of all, sorry, there we go. So first of all, what are MSCs and why do we care about them? So mesenchymal stem cells are plastic adherent fibroblast-like cells that have a certain set of criteria that they have to meet to be considered MSCs. So there are multiple locations where you can collect them from. The most common is bone marrow, and that's what we do in our lab here. They need to have a set profile of what the cell is like. So one of those things is that they need to be multipotent, so they need to be able to differentiate into bone, cartilage, and fat. They also need to have a certain panel of cell surface markers, so they need to be positive for CD29, 90, CD44, and negative for CD45 and MHC2. Importantly, all MSCs are still positive for MHC1. That's what we're going to be talking about. MSCs are also highly immunomodulatory, and that is what makes them such an attractive target for a therapeutic, because they're very potent at decreasing T cell and B cell recognition, as well as dendritic cells. So they're highly immunomodulatory and can be anti-inflammatory. However, like I mentioned, all of these cells, even though they have lower expression than other cells in the body, still have MHC1 on the cell surface. So this MHC1 molecule is really important for the recognition of self versus non-self. But most important to my work here, it's necessary for the surveillance of normal intracellular components. So as you can see here, anything that gets taken into the cell as a part of normal cellular function will get processed and then presented on the cell surface. And so things that are foreign to your body can get recognized via this mechanism and cause an inflammatory response. So previously in the lab, the postdoc before me published this very nice journal article in which she evaluated the use of autologous MSCs compared to allogeneic use, and evaluated the use of fetal bovine serum. So fetal bovine serum is the most common serum supplement in all MSC culture, but obviously it comes from a bovine source, and so is not a natural protein when you use it in a species like the horse or other veterinary species. So our previous method down here, we FITSE labeled some FBS so you could see where the fetal bovine serum was, and not unexpectedly, when you label it, you can tell that the FBS gets taken into the cell, which is expected because it's part of the normal cellular metabolism. And to reduce this amount of fetal bovine serum, we normally, or previously, would use autologous serum instead of fetal bovine serum for the last 48 hours of culture. However, as you can see here, there's a vast reduction in the amount of intracellular fetal bovine serum, but all cells still have some fetal bovine serum in it. Now the question is this FBS of consequence? So up here on the upper right, you can see that the total nucleated cell counts in synovial fluid after injection. And you can see that both the FBS group and the allogeneic group had a negative clinical reaction after injection, indicating that the immune system is recognizing this, even though it's an autologous cell, because of the intracellular bovine contamination. So because of that, because depleting with autologous serum doesn't completely eliminate FBS, we wanted to find an entirely alternative process to using fetal bovine serum in culture. So our goals were first to find just a suitable replacement for fetal bovine serum, and then we're going to evaluate it in vitro in the lab, in vivo, and then also clinically. So when I first sought out or worked on finding alternative fetal bovine serum, I started working with platelet products. So platelet products are the most commonly used alternative in human MSC culture. You can use either platelet lysate or platelet releasate. However, when you try to make these products in the horse, you run into some difficulties. So as you can see up here, when you use a platelet product and you don't remove the fibrinogen, which there's a lot of fibrinogen in equine blood, it'll actually gel your media, make it difficult to retrieve your cells. And so I started doing a releasate product instead, where I removed the fibrinogen and then altered some of the components and growth factors as well. But no matter how much we worked on it, we got kind of the same results that are in the pictures on the right side here. So the cells would grow for 1 to 2 passages pretty well, but after the 3rd passage, the cells would have a change in their phenotype. So they would start to have altered morphology. And then also they would senesce, so they wouldn't keep growing indefinitely like MSC should when you use fetal bovine serum. That's just a picture of our dialyzer. So as these findings that we had are pretty in line with the current literature. So in the horse, it's been documented and published that you can use platelet lysate products, but it's pretty common that there hasn't been anyone to show that these products support growth beyond 3 passages. And they, like the 2020 paper on the bottom right here, shows exactly what we have seen, in that the cells tend to senesce after a prolonged period of platelet lysate. So with running into difficulties with that, we pivoted a little bit. So when working on a clinical case in which bone marrow aspirate concentrate was produced, you have a large acellular fraction of that material left over. So on the bottom of this picture, you can see it's all the cellular material of bone marrow. And then the top is the acellular fraction that's a result of centrifugation. So our thought was, can you instead use this bone marrow supernatant, where the MSCs naturally live in the animal, to replace fetal bovine serum in the lab? So our first step was to evaluate this bone marrow supernatant in vitro. So our objective was to determine if BMS alters MSC growth and function compared to FBS. And we hypothesized that there would be no difference in the isolation, characterization, or proliferation of MSCs in 10% BMS compared to 10% FBS supplemented media. So to test this, Our methods were I collected bone marrow from 6 horses, again through centrifugation, separated the cellular and acellular portion of the bone marrow, and collected the BMS off the top. The cellular fraction then underwent red blood cell lysis, and the remaining nucleated cells were split between 2 conditions. So they were placed in culture in either 10% BMS or 10% FBS. These cultures were expanded until the 3rd passage, at which point the cells were harvested. At the time of isolation, we also plated dishes for colony forming unit assays to measure the isolation capacity of BMS compared to FBS. So after the 3rd passage, we then performed MSC characterization on all of the cell lines. So that's flow cytometry for the cell surface markers, like I mentioned before, trail lineage differentiation. And then on the bottom right here, we performed mixed lymphocyte reactions as a measure of immunomodulatory capacity of the MSCs. So here are our results for this first in vitro portion. So first, when we looked at the isolation and proliferation, we interestingly found that when we measure the colony forming units here, so the total number of colonies isolated from the raw bone marrow, we noticed more colonies were isolated with BMS supplementation compared to FBS. And you can see by the lines there that it's pretty consistent in that almost all of the horses were higher in the BMS condition compared to FBS. On the right side here are the dishes, our representative dishes, where you can see on the left is BMS supplemented, and on the right is FBS supplemented. Although we did see an increased rate of isolation, when you look on the bottom left here at population doubling time, we did not see a significant difference. So population doubling time is measured in days here, with a lower number indicating that the cells are reproducing more quickly. And you can see here BMS is more tightly bunched together, and that they're very consistent in their proliferation. While FBS was not significantly different, there were more outliers in the FBS group compared to BMS. Then when we looked at characterization, we saw no difference whatsoever between the 2 groups in cell surface marker expression. Here, trail lineage differentiation into bone, fat, and cartilage. And on the bottom left here, we saw no difference in proliferation index, which was the outcome parameter we used for the mixed lymphocyte reactions that were performed. However, what we were most excited about was when you look at the pictures down here on the right, these are images from the same horse at the same passage in the same time point, cultured in BMS on the left and FBS on the right. And as you can see, the BMS cultured cells have maintained their normal phenotypic appearance and are actually more confluent than the FBS cells that are on the right. The FBS cells still have good morphology, but they just happen to be less confluent. So the fact that we were able to maintain proliferation with similar morphology and no signs of senescence, we were really excited about this, the use of BMS. So since we were successful in the laboratory, we then sought to evaluate this in vivo in a research setting. So our objective of this aspect of the project was to evaluate the safety and efficacy of autologous MSCs with MSCs expanded either in BMS or FBS. We hypothesized that there would be less adverse response and improved efficacy to BMS MSC recipients compared to FBS. And again, that goes back to what I spoke about in the beginning with the FBS having a potential for immune recognition versus the BMS is natural to the horse and not introducing any foreign proteins. So to test this out, we again drew bone marrow on 6 horses per group. The bone marrow was isolated either in autologous BMS, pooled BMS, which was BMS pooled from horses in the autologous BMS group, or from FBS. Our model that we use is our standard injection model that we use frequently in the lab. So on day 0, the left metacarpophalangeal joint, so fetlock joint in the horse, was injected with 10 million MSCs respective of the treatment group. And then we serially collected synovial fluid on days 1, 2, 3, 7 to perform synovial fluid analysis. We also performed gait analysis and clinical assessment using the lameness locator. And then on days 1 and 7, we collected additional synovial fluid to evaluate synovial MSC concentrations. And on day 1, we performed a Luminex multiplex assay, which is a 23 analyte panel for cytokine and chemokine concentrations. On day 29, we repeated this experimental model, but this time with the addition of lipopolysaccharides. So the LPS in this is to mimic some naturally occurring inflammation. We collected synovial fluid and performed a clinical assessment at the same time points, also assessed synovial MSCs, and also did the Luminex panel. So on to our results. So when we evaluated these results, there were no difference between the autologous BMS recipients and the pooled BMS recipients. Therefore, the data from those groups were combined. So as you see us go through, there will be actually 12 horses in the BMS group and 6 horses in the FBS group. So first, when we evaluated the synovial fluid, on the left, upper left here is the total nucleated cell count, so the number of nucleated cells in the joint fluid that was collected at each time point. So again, the fluid was collected on day 1 is 1 day after injection, and day 30 is 1 day after the second injection. While total nucleated cell count was increased over what is normal in the joint on those days, there were no differences between groups at any time point. On the lower left here, we looked at the percentage of cell type, with the open area being small lymphocytes, the hashed area being large mononuclear cells, and the solid portion being neutrophils. You can see on days 0 and 29, so prior to either injection, that the cell composition was a bit different than days 1 and day 30. But again, there were no differences between groups at any time point. When we performed our Gait analysis, which is our objective measure of pain, we use our lameness locator. So the lameness locator provides you with a vector sum number here on the y-axis. All of the horses were injected into the left fetlock joint. And using this system, left-sided lamenesses are indicated with a negative number. And the higher the number, the more significant the lameness. So as you can see here, after the first injection on day 1, there were 2 outliers in the BMS group, but the rest of the horses were pretty tightly bunched here. And then the median for the FBS horses was lower, although there wasn't a significant difference. This remained the same after the whole first week after the first injection. After the second injection, though, again, when we use that lipopolysaccharide as well to mimic naturally occurring inflammation, the median of the lameness was worsened in the FBS group on all days, and the lameness was significantly worsened on day 32 in FBS recipients compared to BMS recipients. Along with our clinical evaluation, we evaluated the edema and effusion in the joint that was injected. So these were subjectively measured, with 0 being no edema or effusion, 1 being mild, 2 being moderate, and 3 being severe. So on upper left here, we are evaluating the edema, and you can see that there was significantly more edema, denoted by the asterisks, on days 1, 2, and 3. Similarly, when we evaluate the effusion or the fluid that was within the joint, the amount of it, there was more effusion in FBS MSC recipients on day 2. After the second injection, we noted very similar results. So again, an increase in edema in the FBS MSC recipients, as well as an increase in effusion. After the second injection, we also performed a subjective measurement in where we measured the limb circumference at the point of the button of the splint, so we could get an objective quantification of how much change there was. And you can see that the results very nicely match. The change in centimeter here is an increase. They very nicely match the edema results that we had, indicating that there is really an increase in the limb circumference and worsened edema and adverse response in FBS MSC recipients compared to BMS MSC recipients. So next we evaluated the cytokine and chemokine concentrations in the synovial fluid. So like I said before, it was a 23 analyte panel. I've included just some of the more major cytokines and chemokines on this. We interestingly didn't see any difference between groups at any time point, although there were some elevations in the cytokines. So next, I used serum to evaluate anti-bovine antibodies in the horses. So on the upper left here, I performed an ELISA with serum that was collected weekly throughout the study. And this was just the raw optical density reading, which gives you an idea of how high the anti-bovine antibody concentration is in that individual. So the higher the OD reading, the higher level of anti-bovine antibodies. Now, interestingly, you can see that between the FBS and BMS horses, there was no difference at the start, but there was also no difference over time. So the concentrations of anti-bovine antibodies didn't change in any of the horses with exposure. So that was just an overall reading. So I then wanted to directly compare the pre-injection and post-injection concentration of antibodies in just the 6 FBS MSC recipients. So on the right here, again, it's optical density reading, but on the x-axis here is the concentration or the titer at which you're still reading that there are antibodies present. So you can see here, each horse is a different color. And then the days are either the solid gray line or the dotted black line. You can see that the horses are very closely knit together, meaning that their amount of antibody titer, so the maximum titer, didn't change at all between day 0, so prior to injection, or day 56, which is about a month after the second injection. Now, we weren't terribly surprised by this, but the fact that it's commonly known that horses, as well as many other species, can develop anti-bovine antibodies as a result of routine vaccination. So viral vaccines are produced using bovine proteins, and so routine vaccination can result in inadvertent, but really, as you can see here, really thorough vaccination of horses to bovine proteins. And so these horses in our herd were vaccinated twice annually every year for their entire life that they've been here. And so these horses have maximum titers of anti-bovine antibodies that weren't able to change with a small exposure. So even though these titers didn't change over time, we wanted to know if they are actually clinically significant and if they matter to the horse into administering FBS MSCs. So to do that, I performed quite a few microcytotoxicity assays. So you combine MSCs that have been cultured with BMS or FBS with either serum or synovial fluid. And if there are antibodies in that serum or synovial fluid, it's going to result in antibody-mediated complement cytotoxicity and cell death. Those cells will appear roughened around the edges, darker and flat. Now, if there aren't antibodies present, those cells are going to remain round, bright, and alive. That's down on the bottom right there. So I performed this experiment 2 different times. So on the upper left is going to be the percentage of cell death on the y-axis here, and this is going to be time point. And I combined synovial fluid from MSC recipients, the autologous FBS cultured MSCs. So they're their own horses' MSCs and their own horses' synovial fluid. So importantly, you can see here on day 0, before the horse was exposed to any FBS MSCs, there was a sufficient amount of antibodies in the synovial fluid to result in almost 100% cell death in all horses. This antibody concentration stayed consistent throughout the study. So days 1, 7, 30, and 36. So 1 day and 1 week after each injection, the antibodies were still very high in the synovial environment. To demonstrate that this cell death is in fact due to antibodies to bovine proteins, I then took serum from those same horses and exposed them to either FBS or BMS cultured MSCs down here. And you can see that, again, the BMS MSCs survived. There's no cell death, and FBS MSCs had marked death. I then depleted that serum of antibodies. So this column here is just in the buffer for the kit. And then this column is about a 50% reduction after using a protein A column to remove about half of the antibodies. And then down here, this is with complete removal of IgG using a protein A column and separate G beads. And at that time point, once you remove the antibodies, there's now no death whatsoever of FBS MSCs, and it looks the exact same as BMS MSCs. So because we know now that antibodies are present and antibodies are in the synovial environment before you even inject a cell, we wanted to look at if this is going to affect your efficacy of the cell itself. So this brings us to the synovial MSC concentrations. So this is the synovial fluid that was collected on days 1, 7, 30, and 36 and plated to these CFU dishes here. On the top is a representative image of a horse that was a BMS MSC recipient. So you can see lots of synovial MSC colonies. And on the bottom right here are FBS MSC recipients, so very few to none. We broke down it in two different ways to look at. So on the upper left here is your proportion of CFU positive. So the entire bar is how many samples were collected. So again, there's 12 in the BMS group and the maximum is 6 in the FBS group. The solid portion is if they were positive, so they had at least one or more colony present. And then an open portion is if there were no colonies present whatsoever. You can see that there were significantly greater proportion of positive plates on days 1, 7, and 36. Then when you look at it, when we quantify the number, so this is counting the number of colonies on the plate here, you can see that the median number of colonies is higher in the BMS group on all days and significantly higher on day 7. You can see that there's quite a few outliers here and that the BMS horses have quite a few colonies and there's only 1 to 2 in the FBS group that are able to have some synovial MSCs. So for this portion of it, we demonstrated in a research model that if you remove the Xenogen contamination, so you eliminate FBS entirely, it mitigates that cell death and then also adverse clinical response. We noted that again by there being increased edema and effusion or an adverse reaction in FBS MSC recipients, which was not present in BMS MSC recipients. There's also marked autologous MSC death with intracellular FBS, where there was not with BMS. And then lastly, we noted improved or increased in vivo efficacy, which we demonstrated by an increased number of synovial MSCs, which are endogenous progenitors, which can be really helpful in the healing process of joint damage. And then also there was less lameness after the second injection with LPS in the BMS group compared to FBS group. So now that we've gone through and made sure that it works in vitro and then also in vivo, that it's very safe and there's a potential for improved efficacy, we wanted to test this out in horses that have naturally occurring osteoarthritis. So the first case that we had presented to us and the first horse that received these BMS MSCs that are Xenogen free was a 13-year-old quarter horse gelding. He was 4 out of 5 lame on the left front and non-responsive whatsoever to intra-articular steroids, which is the conventional therapy for an injury like this. He also had marked calf and joint effusion and a pretty significant articular cartilage lesion, which you can see in these images, as well as some osteoarthritic changes. This horse, based on his lesion and MRI images, had a pretty guarded prognosis for return to function, but as a potential for therapeutic, we decided to try BMS MSCs with him. So he was diagnosed back in July of 2018, and then he received 3 injections of BMS MSCs, again, all autologous. Remarkably, by that fall, he was sound. He received another injection and then was able to return to work in January of 2019. Since then, he's received a few kind of maintenance injections to maintain his soundness. But to this day, he's still in work and still sound on this limb, which was pretty remarkable. So after this, we in our lab switched almost entirely from using conventionally cultured FBS MSCs, where we depleted that fetal bovine serum for 2 days, and now instead are using just this BMS MSC method, in which is a totally autologous product that we're being able to produce in the lab and then put back into the horse. So from 2018 on, we've started using this, and then this last portion is a retrospective analysis of the outcome of horses that had received these autologous Xenogen-free MSCs that were produced in our lab from June of 2018 to October of 2020. So for this, our inclusion criteria was pretty standard. So cases that had received autologous MSCs prepared in the Xenogen-free media. They needed to have lameness localized by diagnostic anesthesia or clinical examination. And they also had to have diagnostic imaging supporting the diagnosis. We collected information from the record, including signalment. If they had previously failed to respond to conventional therapy of intra-articular steroids, what their lesion type was, so osteoarthritis or OA, articular cartilage lesion here, or subchondral bone loss. We also graded the lesion severity as mild, moderate, or severe, and recorded the number of MSC injections, and then the current level of exercise, so stall rest, partial work, or full work. So for our results, first are our demographics. So there were 18 horses that met this inclusion criteria. This is the breakdown of them. So up on the left up here is the gender, not terribly unexpected that there were most commonly geldings, as those are commonly performance horses, but we also did have some stallions, and that included mares as well. On the upper right here is the number of joints treated. So the majority of horses had just one joint treated. A few had two joints treated, so that could have either been a bilateral treatment of the same joint, so say coffin joints on both sides, or an alternative lesion. And then there was one horse that had three joints treated. As far as age on the bottom left down here, pretty equal distribution across the board. So the ages ranged anywhere from 2 to 20 years old, with a pretty equal spread in each age bracket. As far as breeds, there's a bit of an overrepresentation of quarter horses and then also warm bloods, but that just happens to be kind of the demographics that we see in this area. And we did also have one saddlebred and one Andalusian included. As far as disciplines, again, we're perhaps a little bit over represented in the dressage category. And then in show is mostly Western quarter horse all around show type horses. But we also did have a barrel racer, a reiner, and a hunter. So through the next couple of slides, I have some images of the lesions, so you can kind of see what the diagnostic imaging was that we deemed as acceptable and included. On the left here, it's the distribution of the lesions by the primary joints. So the most frequent lesion that we saw was the distal interphalangeal coffin joint, followed by the fetlock joint. For the secondary lesion, the most common was the radiocarpal joint, but we also did have a fetlock joint and some distal hock joints that were included as well. Now, when I looked at the lesion type and severity, the majority of horses, so 2/3 of the horses, had articular cartilage damage, so they could have also had osteoarthritis signs of enthesiophytes and osteophytes, but they had a full thickness cartilage lesion as well. And then on the left here, the subchondral bone loss, there's 6 horses, so they had a full thickness cartilage lesion plus bone loss deep to that. And on the lower right here is our distribution of severity. So only 3 horses had mild injuries, 6 had moderate, and then half of the horses, 9, had severe injury. So this table here kind of sums up the majority of the data. It's a little bit daunting to look at, but I'll walk you through it. So on the upper left here, this is just the horse number. This column here is whether the horse previously responded to steroids or not. If they failed to respond to steroids or not. So if they had failed to respond, they're in blue here. As you can see, the vast majority of the horses had previously failed to respond to conventional therapy. And then the next column over is important because it's if the horse had surgery performed or not. So if the horse had surgery, it also had this kind of lilac color yes here. But as you can see, there are quite a few horses that did not have surgery that had previously failed to respond to conventional therapies. When looking at the rest of the table here, these are months at the top here. So month 1 is where they started treatments. And in the boxes are the number of treatment that they received. So first treatment in the first month. Then the color coding is if they are not in work, so they're on stall rest, is going to be red. If they're on partial work, it's going to be this yellow color, and then green is in full work, total return to function. On the right side here is the outcome. So we had a full 12 months follow-up on all but 2 horses. We had 10 months on one, 11 months on the other. As you can see, the majority of horses returned to full work and stayed in full work, with a couple horses that became improved on their original lameness, so went back to work for a portion of time, and then lameness developed on the other limb, and 1 horse was lost to follow-up. 1 was euthanized due to severity of disease, 1 elected another therapy, and then 2 improved but were not resolved, and so were retired for performance at that time. So overall, our conclusion from this was that the cases we treated were pretty severe, and that 78% were refractory to conventional therapies. Surgery was performed in only 39% of the horses, so not the majority. Follow-up was available on 17 horses, with again that 65% rate of return to function of all of those horses returned to full work and were able to stay in full work. 11%, 2 of those horses returned to full work but became lame on a different limb. 11% improved but were retired. 6% elected other therapy, and 6% were euthanized due to severity of disease. So we can't in this provide a direct comparison because of the fact that we were not using FBS MSCs concurrently. However, this return to work is improved over previous clinical reports. So our next step is to perform a clinical trial, and that is with the help of the Grayson Jockey Club has supporting us in this. So our clinical trial, which we actually started last September, we're directly comparing the use of FBS MSC, so the way that we used to previously culture them with fetal bovine serum that's removed for the last 48 hours, and then comparing it to BMS MSC. So horses are enrolled if they have osteoarthritis of a high motion joint, and then they are randomly assigned to treatment group so that we can administer these therapies in a blinded manner and have a really objective evaluation of the use of BMS MSCs compared to conventional MSCs. So this is just a little summary slide here, in which you can remember back to the beginning that that fetal bovine serum gets taken intracellularly and then is presented by normal cellular processing on MHC1. And then horses all routinely have, antibovine antibodies due to that routine vaccination that occurs for viral pathogens. And those antibodies are of consequence in the joint, and that they cause cell death of FBS MSCs, which is eliminated by the use of BMS. So that about wraps up everything that I have. So I'd like to acknowledge first my committee chair, Dr. Ashlee Watts, and then all of my committee members, Katrin Henricks, Michael Piscicello, and Carl Gregory, as well as our lab members, and then all of our sources of funding, of course, the Grayson Jockey Club, as well as AEP, USDA, AQHA, and then the endowed chair for equine studies and Link Endowment for Equine Research. Are there any questions?
Yeah, and for those on, if you have a question, you can use the Q&A button at the bottom, but there were a few questions, some of them more in a more general fashion as well.
Yeah.
And the first one was, and you may have said this in the past, but somebody, or in the beginning, but how is this a quicker preparation method for these types of MSCs compared to the other ones, and how much time are you kind of saving in the process when this gets to real in the clinical setting, you know?
Yeah, so the amount of time it takes to culture them is the same. So it takes about 2 to 3 weeks to go from drawing the bone marrow to having it ready to inject into the horse. So there's no difference in the time there. But the main benefit is that you're not using that fetal bovine serum, which is a foreign material, and you're using the horse's own material. So it's as close to autologous completely as you can get, with minimal manipulation in the lab.
Gotcha. And that's just to benefit the horse with a more natural substance being connected back. And then another one is about the first trial you did, and I think it was in, you may have said a high motion joint, and that was, how was the fetlock selected for the first study?
Yeah, so the fetlock we use pretty commonly as our model because one, it's high motion, like you said, so it articulates between the cannon bone and the long pastern, so pretty high range of motion. It's also fairly easy to access, but most importantly, as a joint, you're able to extract a large amount of synovial fluid from it, and the horses are pretty amenable to it, so it's easy to access, easy to inject into, and easy to get synovial fluid out of. It's also not really constrained. So like a coffin joint is constrained within the hoof capsule, whereas the fetlock is very easy to see. You can see if there's joint distension, you can see if there's edema around it very easily. And it's very easy to quantify as well.
Right. And this kind of a follow-up question that somebody had about it, which was, they're all injections directly into the joint. They're not a systemic stem.
Correct. Yep. So we use direct injection into the joint versus systemic because in systemic administration, you may not see the immune reaction that we see in the joint. So the joint's an enclosed environment. So there's a blood joint barrier to it. And so it's going to hold those MSCs in there. And then if there is inflammation, like we demonstrated, you're going to be able to see that inflammation, which you may miss if you were to administer it systemically.
Yeah, so I guess somebody asked, and that allows you to collect all that information that you did because you're in a closed environment and not kind of a guesswork shotgun approach, let's say.
Correct.
And then the last question, unless any more come in, was you mentioned the lameness locator earlier in your presentation. Did you use the lameness locator throughout when you got the horses from the clinical trial as well?
Yeah, so when this data I presented was just retrospective data, so we don't have lameness locator on that. For the clinical trial that we're performing right now, we do. So we do use the lameness locator both at the baseline exam and then at 2 follow-up exams. And so we do use it for that. And that's a good quantification and measurement of improvement because lameness grade and scoring can be, there can be a wide range of a horse that say is a 3 out of 5 lame. Versus the lameness locator is going to give you a precise number and be able to say that the horse went from a 30 to a 15 and give you a good amount of improvement.
Yeah, and I guess you'll use that with observations and the other.
Absolutely.
Well, and then the horses that you get in that you're doing your study with, are these horses that are being treated at the clinic, or do you go out and look for them, recruit them? How do you get those horses that?
So they're horses that present for lameness to Texas A&M University. So quite a few of the referring veterinarians in the area know that we have this study going on. So if they have a horse that meets the criteria, they'll often come to us for evaluation. And then we determine if they're eligible to enroll in the study or not. If they're eligible to enroll, then we offer that as an option, and that we would like to be able to enroll them in the study if possible, but it's up to the owner's discretion if they choose to enroll or not.
And this is the last question, which is, do you think that you'd see the same results in other joints outside of the fetlock, or other, band on what you believe this would also be useful for outside of just that application?
Yep. So any high motion joint with a cartilage lesion, we expect to have good results in. Most commonly in our clinical trial right now is the coffin joint. So most of the horses have coffin joint lesions, which is can be a difficult joint to treat, so it's perfect for using with MSCs. The only joints that we really don't include in the study and aren't looking to enroll are lower hock joints. So those are low motion joints, and they don't have quite the same anatomy and makeup as a joint like a fetlock or a coffin or the tarsopectoral joint, so the big joint that's in the hock. So we don't include the lower hock joints, but other than that, just about any joint can be investigated using this.
So it's an ever evolving field. And as a lot of you've shown, it doesn't matter what age you are, or what your job is, or what your breed is. This osteoarthritis, and especially in these high motion joints, is going to be prevalent in a lot of our horses. So continuing focus on treatment of it's just going to be a key thing as long as we're still using the horse in a performance fashion.
Yeah, exactly.
Well, Aileen, I just want to say thank you again for taking your time again today.
Yeah,
To the Klein family for providing the Elaine and Bertram Klein Award every year. Like she said, it's very nice to receive recognition for what you're doing at this stage in your career. So thank you for the Klein family. And Dr. Rowland, thanks for taking your time today. And I'll let you know when we get this posted.
of course. Great. And thank you very much again for the support. I do really appreciate it.
Yep. Great day, everybody. Bye-bye.
Okay.